Great. Thank you so much. So I'm going to be presenting the data from the NADIM study. So this study is a phase 2 trial study, and the earlier results were actually released in September 2020. And here I'm going to present the long-term survival data, which was presented in September 2021 at the World Conference for Lung Cancer. Next slide, please. So we all know, it has been repeatedly said that of the 80 to 85% cases of NSCLC of the lung cancers, almost a third belong to stage 3. And these patients have a dismal prognosis with a median OS at 3 years of only 30%. And despite a multimodality treatment, we often see that their outcomes are poor, and a micrometastatic disease would already be present when you are talking about an N2 node. And most of these relapses, these patients, whenever they relapse systemically. So addition of radiation did not show any benefit. Next slide, please. So the idea behind the NADIM trial was, next slide, please, to look at the role of chemoimmunotherapy. So why do we even give neoadjuvant therapy? So it is to make the downstage the tumor and make resection feasible. It also addresses the micrometastatic disease early on. And by giving neoadjuvant therapy, we are trying to assess the response and thereby see if we can predict survival based on the response. Of course, we run the risk of losing the window for operability. And if the patient suffers a lot of toxicity, the patient might not even be fit for surgery. Despite these nuances, of course, neoadjuvant therapy has proven to be useful. And let us look what NADIM trial has to say about this. So as already mentioned, the absolute benefit with chemotherapy has only been 5%. And here we are trying to see how we can increase this number and how we can increase the survival of 30%, further increase it. Next slide, please. So the rationale is that early on, when the entire tumor is present, more antigens would be exposed. So probably the body would mount a better anti-tumor response. And because the immune memory is created beforehand, this would probably provide a long-term protection. Next slide, please. So a lot of trials have already been done. Checkmate 816 data was just presented, and like Dr. Bhavish already presented the pembrolizumab data also. All the immunotherapies are being experimented, and definitely the results have been encouraging. Next slide, please. So of course, there are differences between these different trials. Only 816 was a phase 3 trial, rest all are phase 2 trials. That is the only randomized data. NADIM was a non-randomized study. The stages included have been variable, but NADIM study only includes stage 3A. Some studies have a control arm. This study does not have a control arm. Exclusion based on the mutations was done again in only some studies. Sample sizes have been highly variable. The endpoints, like the 816 looked at PAT-CR. Here, this trial looked at feasibility and also the survival outcomes. Next slide, please. So is PAT-CR really predictive of survival? This is a question which has been haunting us oncologists from a long time, but we don't have a answer for this right now. But definitely it's a potential surrogate endpoint for lung cancer. Especially, this has not been validated because so far we were only using chemotherapy, and chemotherapy was not giving that high PAT-CR rates to be able to know whether this is really a potential surrogate marker. Next slide, please. So the NADIM study, this is a single-arm phase 2 trial. This was done across 18 hospitals in Spain, including histologically proven NSCLC patients, and they excluded the patients who had EGFR mutations or ALK translocations. These were pathologically proven stage 3A disease, and medicinal evaluation pathologically was already done at the baseline, either using endoscopic ultrasounds, if needed, even a thoracotomy. The staging has been based on AJCC 7th classification, and performance status of 0 to 1 were included. They enrolled patients between April 2017 to August 2018. During this time, they screened 51 patients, of which 46 patients met the criteria. With this number, the study is 80% power to detect a 15% improvement in the PFS. Next slide, please. So this is the study design. Stage 3A NSCLC patients, they went on to receive neoadjuvant treatment with nivolumab, paclitaxel, carboplatin once in 3 weeks. They chose this because of its success already in the advanced stage, and that's why they wanted to use the combination. And After receiving 3 cycles, at a gap of 3 to 4 weeks, patients underwent surgery. After the surgery, they received adjuvant therapy for 1 year. First 4 months, 2 weekly nivolumab were given, and later on monthly nivolumab injections were given. Patients were followed up for 3 years. Now, during this entire time, at different intervals, blood samples were collected to look at the circulating tumor DNA levels, and the tumor blocks were also studied to look at the tumor infiltrating lymphocytes. Next slide, please. So the pathological response could be a complete, major, or incomplete response. We already know the definitions. The ctDNA was looked at before and after NACT, and then 6-monthly interval. They also looked at the CD8 positive tumor infiltrating lymphocytes. PD-L1 expression was studied to see if this could predict survival or response, and this was a pre-specified exploratory endpoint. Also, they looked at tumor mutational burden to see if it could identify resistance mechanisms. So the intent to treat population was defined as anyone who received neoadjuvant chemotherapy. Per protocol population is the one who had included the patients who had undergone resection and received at least 1 cycle of adjuvant therapy. Next slide, please. The response assessment was either radiological, pathological, or depending on the circulating TNA clearance. Next slide, please. So at early results at the in September 2020, this included the follow-up at 24 months, and 35 out of 41 who had undergone tumor resection were disease-free. So at 24 months, the PFS was 77% in the intent to treat population, and in the per protocol population, it was 88%. OS was 88%. 30% of the patients had grade 3 or higher toxicities. Next slide, please. So now talking about the long-term survival data of the same study arm. Next slide, please. So the study objective was, the primary endpoint was to look at the PFS at 24 months, and the secondary endpoints were to look at downstaging rate, complete resection rate, response rate, pathological responses, of course the safety. Along with all of this, they also wanted to look at OS at 3 years, and this was a secondary endpoint. So this slide also includes the results. So a PFS at 24 months was 77% in the intent to treat population. The secondary endpoints, 90% patients had downstage tumor, and 89% could undergo complete resection. The overall response rate were high, 76%. Complete pathological response in 63% patients. Only 30% patients had a grade 3 or worse toxicity, which I'll be, why do I use the word only? I'll be telling that in the next few slides. There was no loss of life to surgery. So now this long-term follow-up data is at the follow-up of 38 months. So out of the 46, 41 patients could undergo tumor resection. 37 patients went on to receive the adjuvant therapy, of which 58.7% patients could complete the entire treatment plan. However, of the intent to treat population, 12 patients had progressed, and 9 patients were lost their lives. Now, of these 9 patients, 3 could not undergo surgery and had disease progression. 4 underwent surgery but had disease progression. 2 lives were lost to COVID. Next slide, please. So this is the PFS data at 3 and 3.5 years. In intent to treat population, 70%, and per protocol, 81%. Next slide, please. This is again OS data at 3 years. It is 82%. This is so impressive. In per protocol population, it was 91% at 3 years. Next slide, please. So they tried to look at different responses and how did they correlate with the survival. So they found that only the circulating DNA correlated statistically with the survival. The radiological response and the pathological response did not correlate. Next slide, please. This is the adverse event profile. No lives were lost due to toxicity, and most of the patients had either grade 1 or grade 2 toxicities. Next slide. This during the neoadjuvant, and this slide shows the toxicity during the adjuvant phase. Again, most common were grade 1, grade 2, no loss of lives to the toxicity. Most common grade 3 toxicity was increase in lipase or serum amylase increase or adrenal insufficiency. Next slide, please. So this trial concluded that these results are definitely encouraging. The nivolumab and with chemotherapy is safe, and like I said, circulating DNA correlated with the survival. Next slide, please. This is a separate analysis. This was published separately. They found that at the baseline, the patients who had higher circulating DNA levels, they had lesser PFS when compared to patients who had lower circulating DNA at the baseline. Next slide. So they found there was no association with PD-L1 expression, TMB, with survival. And when they looked at the tumor infiltrating lymphocytes before and after the neoadjuvant therapy, there was a drastic decrease in the tumor infiltrating lymphocytes, increase in the memory cells and Treg cells. Next slide. My take on this, definitely promising approach, and we have more data from 816 also. However, there's no biomarker to choose these patients. Shortcoming of NADAM studies, it's a small sample size. There was no control arm. We'll have to probably wait for further studies and event-free survival data of 816. Thank you so much.